let's spend few moments with intercoronary imaging and physiology. So, what is the aim of interventional cardiology? If we think, we have two fundamental questions and two basic decisions when we deal with the patient. The first one is the lesion significant or ischemia producing, and should it be treated? And the next one is, has the PCI been optimized? To get the answer of this question, we have to deal with the intercoronary imaging and physiology. So, from this, that's the term come from that is precision intervention. That is related to the perfection of intervention. So, it is covered by IVAS, OCT, and the main thing is the CAG. Around this, the rest of things are persisting. There is FFR, virtual histology like this. So, what guidelines says about these techniques? All the guidelines already adopted this in class 2A or class 1 indications. IVAS and OCT in the 2A, whereas FFR in class 1 indication. So, all the time we follow the guidelines, so this should be followed. Now, what is the current status of PCI management? Let's start with the physiology, because it's the basic of intervention, because we have to prove that there is ischemia is present physiologically. That's why it's in the class 1A recommendation. So, what is done in FFR, this fractional flow reserve, is nothing but the pressure measurement proximal to the lesion and distal to the lesion. We put a normal wire that is equal to PCA wire that have a tip that has the pressure sensor. So, this is the distal pressure, and the proximal pressure is measured by the catheter tip itself. It has been observed, several data has showed, FFR guided multivessel spending reduce urgent revascularization compared with infarculated artery on listening in STMI patient. What is done in FFR is the normal procedure. We put the wire, and it is initially we cross the tip of the catheter and equalization of the pressure. Then it is sent to the distal of the stenosis. Then the pressure is measured and is compared by the machine. Then from this measurement, we have to at first create the hyperemia. It is usually done by several agents, and mostly in our country we use the adenosine, but in Singapore or Japan they use the ATP. But if there are some issues whether this hyperemic agent is equally effective intracoronary or intravenous, there is some important points. If we want to pull back tracing, to get this we have to give it infusion in the intravenous route, and when we want to the state result, we can give it in the intracoronary route. It is observed that most of the time we use intracoronary route, but intracoronary route we cannot get the pullback tracing result. So, FFR is when it is 1, it is taken as normal. Several data has proved when the FFR value is less than 0.75, it is equal to ischemia producing lesion, and its specificity is 100% and predictive value is 100%. And when it is more than 80, negative ischemic result predictive accuracy is more than 95%. But there is some fallacies, or there is some relative indications and contraindication. Most contraindication when the rate is less, as because we know adenosine causes bradycardia, and when patient is suffering from asthma. There is some other issues where we can get the false results, such as when we deal with a long lesion, diffuse disease, or there is multiple tandem lesion, or when the bifurcation lesion or left main disease. And another issue is acute coronary syndrome setting, what the IVS result or FFR result predict. Now let's talk about the long diffuse and multiple lesion. Suppose in this lesion, there is multiple diffuse disease. What should be the IVS or FFR result interpretation will be done? It is our real world scenario when we face the problem. There is multiple tandem lesion and we are doing FFR, but we are in puzzling situation to take the decision. So the solution is, when there is multiple lesion, we must take several FFR values after crossing each lesion. When we get the lowest lesion, this should be corrected first. Then again FFR done crossing each lesion. Then next issue is done. But what we should do when both the lesion is equal? It is mentioned then distal lesion should be done first. So this is the way when we can cross the long diffuse and multiple lesion. But what will be the issues in left main disease and bifurcation lesion when there both involve the LED or LC ostium. If left main is involved in the ostium or in the shaft, we cross the lesion and measure the FFR, that is okay. But when there is bifurcation lesion, we should to take two results, both crossing the LED, left main to LED, and both crossing the left main to LCX. And we have to take the lowest limit, because in one lesion we may get the fake normal lesion. Now, this is a very important issue when we deal with ACS patient. ACS patient, there is thought that FFR is not actually projecting the actual scenario, but the fact is not like this, because in non-decision taking about non-culprit lesion, this is the technique who will give us the way to take decision about the non-culprit lesion. If non-culprit lesion is significantly found in less than 0.7, then we should treat it. Another issue is the culprit lesion, this is the responsible for the ACS, it is get the fake result due to microvasculature dysfunction, microthrombi, etc. But it has been observed in the real world that 85% cases they give us the accurate result, because both proximal and distal pressure are equally dampened, and then the ratio is remain the significant. After getting the result of the FAME2 trial, it has been the issue is solved. So because we have found the death, migraine infarction, urgent revascularization, in all cases FFR is give us the beneficial result. Now talk about the IVAS or OCT. IVAS and OCT should be discussed first together, because some of parties says they are friend, but rest they are an enemy of each other. Actually, to us, they are supplement to each other. But what is the matters related to this? Because IVAS is based on sound, whereas OCT is based on the light. So when we want to see the thin fibrous cap or thrombus or calcium, in this situation, OCT give us the actual result. But there is calcium, this give us, IVAS give us the best result. Another thing is, to get the osteal vision or picture, then IVAS gave us the actual pressure. So this is the thing. This is the view picture of IVAS. Stent measurement, stent malposition, calcium. And there are several artifacts related to the air, catheter, side lobe, etc. This is the case scenario. What we can see, the different segment level shows different picture. Some shows the soft plaque, some showing the fibroatheromous plaque, and some showing the calcified, because a single lesion may give us the all picture. So it should be dealt accordingly. So after standing, we can see, we can measure the main lumen area, or after there, whether is dissection or not, where stent is malopposed or there is under expansion, we can easily get by IVAS. So we can reduce the risk of MACE by 41%, mortality by 54%, and stent thrombosis by 51%, just using the IVAS. So our take-home message is, our previous already showed there is 50 running cath lab, but only few have IVAS and FFR. ADLA guideline directed PCI we are talking always, but we are not using these techniques, because we know they improve outcomes by reducing mortality, by reducing MACE, by reducing stent thrombosis. And the another thing is, FFR also reduce significantly the unauthorized use of stenting, that is statistically significant. Thank you.
তুমি যে এফএফআর এর যে বললা যে লেস দেন 0.75 সিগনিফিক্যান্ট 0.80, মাঝের যে 0.75 এবং 0.80 এটাকে বলে গ্রে জোন,
রাইট স্যার।
ঠিক আছে, এই গ্রে জোনে যদি কারো থাকে তাহলে এটা হচ্ছে যে পেশেন্টের সিমটম, হিস্ট্রি এগুলোর উপরে তখন ডিসিশন নিতে হবে।
রাইট স্যার।
আরেকটা জাস্ট একটা টেকনিক্যাল পয়েন্ট, সেটা হচ্ছে যে আমাদের দেশে তো, আমাদের দেশে কেন পৃথিবীর সব জায়গাতে এফএফআর সব পেশেন্টে করা হয় না, ঠিক আছে। একটা ধরো যে তুমি যে মানে 90% এলইডি লেশন আছে মনে হচ্ছে ও নেকেটাইতে, সেখানে তো এফএফআর করার দরকার নেই। এফএফআর আমরা সাধারণত করি হচ্ছে যেটা বর্ডারলাইন লেশন। এই জায়গায় একটু মানে ট্রিক্স বা একটু ইয়েটা হলো যে এলইডিতে যদি তোমার 60 to 70% লেশন হয়, তাহলে এটা এফএফআর করতে হবে। কারণ মানে এটা তোমার 70%-এর নিচে হলেও এটার চান্স অফ মানে তোমার ইস্কেমিয়া দেখা যাবে যে এফএফআর এর লেস দেন 0.75 হওয়ার চান্স বেশি। কিন্তু এই লেশনটায় যদি এলসিএক্সে হয় তো 60%, তুমি কিন্তু এটাকে মানে ধরে নিতে পারো যে এটা চান্স অফ ইস্কেমিয়া মানে হওয়ার চান্সটা কম। সেক্ষেত্রে এলসিএক্স হলে তুমি মোর দেন লেশন 70% প্লাস হলে তুমি এফএফআর করতে পারো যদি কনফিউশন মনে অ্যারাইজ করে। কিন্তু রিমেম্বার এলএডির ক্ষেত্রে 60 to 70 বা 65% হলেই তোমার এফএফআরটা করা উচিত। এটা অ্যাভয়েড করা যে আমাদের মানে দেশের কনটেক্সটে সবার যেহেতু আমরা এফএফআর করতে পারবো, এটা একটা জাস্ট ওইরকম গাইডলাইন না, কিন্তু মানে প্র্যাকটিক্যাল যে বাইরেও ওইরকম কুইজ প্রতিযোগিতায় কিন্তু দেয় যে দেখা যায় যে এলসিএক্সে লেশন আছে 60 to 70% চান্স অফ তো ওইটা রেজাল্ট হলো যে এটা চান্স নেগেটিভ হওয়ার বেশি। ঠিক আছে, থ্যাংক ইউ।
আচ্ছা, একটা ভালো পয়েন্ট আমি বলি, সেটা হচ্ছে এখন যে আপনি আরিফ এফএফআর এর কথা বলছেন, হ্যাঁ, যে আমাদের কন্ট্রাইন্ডিকেশন কোথায় কোথায় ব্র্যাডিয়ারিথমিয়া অথবা অ্যাজমা, এটা কিন্তু ওভারকাম হয়ে গেছে। এখন এটা তো বোস্টন সায়েন্টিফিকের প্রোডাক্ট একটা, এই এফএফআর কে এখন ডিএফআর করে ফেলছে।
Because now they have launched the IFR.
IFR,
There is
even DFR.
no use of vasodilating agents.
So you don't have to use adenosine, as a result you don't induce any bradyarrhythmia. So in that case it's safer to use
Yes, sir.
IFR.
Use IFR.
The only you have to upgrade your
Because the same machine, it can be done with the same machine.
Yeah.
And the same catheter it
Same
can be
thing.
done.
Even you don't have to.
Thank you, Dr. Arif, for your nice lecture. My question to the panelists is that what is the role of FFR in suspected case of left main ostium? Is there any role or not? Number one. Number two, when there is microvascular disease, absence of in the case of absent myocardial blush, or when there is grade 2 myocardial blush, or when there is grade 3 myocardial blush, what should be the difference in FFR, and how should we calculate and in making decision?
Thank you, sir. Number one thing is FFR is a method that actually judges the whole myocardium, whether there is microvascular disease, whether there is any geoparadise, or there is microthrombi that is not usually visualized by angiogram, normal angiogram. So when there is, one thing is that left main ostial disease is mostly underestimated through coronary angiogram. So in that situation, FFR is the best technique, best tool to assess the severity of the lesion.
Ostium.
LED ostium, right, sir. LED ostium, LCX ostium, both the left main ostium.
Problem is that if there is other lesions, question is that sorry sir, if there is LC lesion in other lesions, what
in
can
that
do?
case we have to measure the both FFR. If we found the LCX case is significant, then we have to treat it first. Then again we have to measure the FFR in the left main ostium. Another thing is when there is microvascular disease or there is microthrombi that is not visualized, in that case FFR is the best tool to assess the significance of the ischemia.
But one thing is, remember, FFR sometimes is misinterpreted us. We should do the IFR. But in the NICVD,
things, right,
NICVD we have the IFR. In the
Right,
NICVD we have the IFR. So we did the IFR. But FFR is, hyperemia is most important in the FFR. Hyperemia. How much, given the adolescence, how much hyperemia is produced in the FFR is a problem. So in case of more blushing,
Yes, sir.
in that case, the IFR is more than the FFR. IFR is superior than the FFR.
This issue is resolved after installation of the IFR, and later on more techniques also in the field, but it has been found they're almost equal result.
না, আইএফআর তো ডিফারেন্ট ক্যাথেটার ইউজ করে, কিন্তু ডিএফআর যেটা চালু হয়েছে সেটা সেম ক্যাথেটার, সেম জিনিস, খালি ইয়েটা চেঞ্জ করবে, সফটওয়্যারটা চেঞ্জ করবে। এটাতে দেখা গেছে যখন হাইপারএমিয়া করতে না, আমরা কিন্তু ট্যালি করে দেখছি এফএফআর ডিএফআর এর রেজাল্ট সিমিলার, 0.8, 0.7, whatever result comes, a similar result আসে।
And the result given is in very short period.
So our next presenter,